Thank you very much. So the title of my talk today is about Prasugrel and ACS and PCI, because that's the patients in whom it's indicated, and specifically about balancing the risks and benefits, which is what we really do as clinicians every day for every one of our patients. These are my disclosures. I do receive research grant support from a number of pharmaceutical manufacturers, including Eli Lilly and Daiichi Sankyo, who co-market Prasugrel in the United States, also ACS Pharmaceuticals and AstraZeneca. And this is the indication statement, which I was told we need to show as part of this talk for Prasugrel in Israel. It's a little different than the one we see in the United States, but it says that Effient co-administered with aspirin is indicated for prevention of atherothrombotic events in patients with ACS, that's unstable angina and non-ST elevation MI, or ST elevation MI, undergoing primary or delayed PCI, and that the increased efficacy should be balanced with the increased risk in patients with bleeding tendency, especially in those who had a previous history of stroke or TIA, those who are elderly over the age of 75, and those who are low body weight, less than 60 kilograms. And we'll talk about why that is in a moment. So this is a slide that I've shown for a long time, just about what happens in the cath lab. And in the cath lab, we do PCI, which really is a perfect model of a ruptured plaque, because we put in a stent or we do a balloon angioplasty, and this leads to plaque rupture and fissure, which can lead to in situ thrombus formation and microembolization. And we've also known for a very long time, more than 20 years, about the critical role of the platelet in complications in the cath lab. This is a study, landmark study published in the New England Journal of Medicine more than 20 years ago now from the Montreal Heart Institute, showing the benefit of aspirin, simple aspirin, in reducing the incidence of abrupt vessel closure in patients undergoing balloon angioplasty. Really the first study to show the benefit of antiplatelet therapy in PCI. And it's interesting to think that after this study, we started doing coronary stents, and I don't know if any of you started doing stenting as early as I did. I started doing stenting when I was a cardiology fellow in 1991, 1992, and at that time there was very high risk of stent thrombosis, which we were preventing at that time with very, very heavy doses of anticoagulants, including heparin, dextran, and warfarin. And it wasn't until a series of studies in the mid to late 1990s, one of which we worked on at Harvard, called the STARS trial, which showed that the combination of aspirin plus ticlopidine, shown here in the bottom curve, reduced the risk of stent thrombosis by 90%. And this really revolutionized our approach, led to the standard of care of dual antiplatelet therapy in patients undergoing PCI with dual antiplatelet therapy, which at that time was aspirin plus ticlid, and has really been with us today. And as a result of that, we've really learned a lot more about the platelet. Again, when I was in medical school, the platelet was just a sac that contained a number of granules that were released, but we really had no idea of the physiology of what was going on with the platelet. Now we know that there's a number of different receptors that are on the surface of the platelet, and we have pharmacologic antagonists for many of these different receptors. So historically, we have aspirin, which inhibits the production of thromboxane A2. We have historically, again, had the P2Y12 inhibitors, which previously were ticlopidine, more recently clopidogrel, and we're going to be talking about one of the newer ones, Prasugrel, in just a moment. And then, of course, we have the parenteral glycoprotein 2B3 inhibitors, which work at the final common pathway of platelet aggregation. But we're going to focus today, of course, on the P2Y12 inhibitors, the oral drugs up here in the upper right-hand corner. And in particular, we're going to talk about one of the new kids on the block, which is Prasugrel. I think, as most of you are aware, this is a thionopyridine, so it's in the same class of drug as ticlopidine and clopidogrel, and it's a prodrug, meaning it has to be converted to the active metabolite to work, but it's a very efficient conversion. There is, importantly, very little to no genetic heterogeneity, so you get a very steady level of the active metabolite from a given dose of Prasugrel. It works very, very quickly in terms of the level of platelet inhibition, and it's a once-a-day drug, which is a very nice property, of course, for compliance with our patients. This schematic really shows the difference in the metabolic pathway for clopidogrel and for Prasugrel. Importantly, clopidogrel undergoes 2 steps in order to be converted from the prodrug into the active metabolite. Both steps occur in the liver, and very importantly, both steps involve the cytochrome system, and in particular the 2C19 cytochrome pathway, which turns out to be a cytochrome that has a tremendous amount of genetic heterogeneity, and as a result, there's a lot of variability in the amount of active metabolite that is generated for a given dose of clopidogrel. Prasugrel also has a two-step activation process, but it's different in that the first step occurs in the gut and doesn't really involve the cytochrome pathways. The second step also does occur in the liver, but has redundancy among the cytochrome pathways, and as a result of this, the active metabolite again is generated in a very, very consistent amount for a given dose of Prasugrel. There's very, very little in the way of a genetic heterogeneity. And what that translates into, as we I think are all aware, is this very consistent level. So this is a study, a healthy volunteer study of patients who were initially given clopidogrel, a 300 milligram loading dose. And what you can see here is the level of inhibition of platelet aggregation. And you can see there is a very, very wide spread in the amount of platelet aggregation, indicating that genetic heterogeneity. But when these same patients were then given a fixed dose of 60 milligrams of Prasugrel, what you can see is all of them got better, all of them had higher levels of inhibition of platelet function, and that variability shrunk dramatically. And in fact, there are virtually no non-responders when you give 60 milligrams of Prasugrel, whereas a very large percentage of patients, more than half in fact, will be non-responders to a loading dose of clopidogrel. So the data that we have clinically for Prasugrel all come from the Triton Timmy 38 trial. And again, I think most of you are very aware of it, so I don't want to really belabor the results, but I want to just review and highlight a couple of important features of the Triton trial. So again, it was a large-scale trial of patients with ACS undergoing PCI. So it's ACS and PCI, two big groups of patients, non-STEMI, unstable angina, but also STEMI patients were enrolled in the trial. About a quarter of the trial population was STEMI. The randomization was a double-blind, highest quality type of trial, and it was to standard dose clopidogrel, 300 milligrams with a 75 milligram per day maintenance dose, or Prasugrel, 60 milligrams with a 10 milligram maintenance dose. Long-term trial, about 14 months of therapy with a primary endpoint of cardiovascular death, MI, or stroke. And here's the data that I think we're all familiar with. In the United States, when we show this, we break it out by the unstable angina, non-STEMI on the left and the STEMI group on the right, because the timing is a little bit different. The main message here, though, is that there's a consistent benefit across both subgroups of patients. In the unstable angina non-STEMI group, about an 18% risk reduction. In the STEMI group, it's about a 21% risk reduction. And the timing is a little bit different. The STEMI group, the benefit is a little more front-loaded. The unstable angina non-STEMI group, the benefit consistent, and they continue to diverge over the entire 14 months of follow-up. There was a price to be paid, as there is almost always with any kind of effective antiplatelet or antithrombotic drug, which was bleeding. And you can see here that non-CABG Timmy major bleeding was increased by about 0.5%. And again, this is over the extended 14 months of the treatment period, and a similar increase in non-CABG Timmy minor bleeding. And both of these are very important bleeds. Remember, a Timmy major bleed is basically a 5-unit bleed, and even a Timmy minor bleed is a 3-unit bleed. So we certainly want to do what we can to limit these issues. So I want to now just use some of the trial data, but look at a couple of very specific issues which come up certainly in practice in the United States as we try to think about how to implement this trial and use this drug in our practice. And one of the common questions that comes up is, well, look at the trial, you only use 300 milligrams of clopidogrel as a loading dose. We commonly use 600 milligrams of clopidogrel. I'm sure that you do as well in Israel. Can I just see a show of hands actually? So how many people loading clopidogrel these days will use 600 milligrams? And how many will use 300 milligrams? Uh-oh. There's one guy who's sticking to the package label here, but everybody else is beyond that. But that's typically what we see in the United States. I think the reason for that is because the 600 milligram loading dose works a little bit quicker and somewhat more potently. So what would the results have been with the 600 milligram loading dose? Well, honestly, we don't know. But we do know a couple of things, which is, first of all, Prasugrel in its current loading dose is still far more potent than a 600 milligram loading dose of clopidogrel. This, again, is a normal volunteer study, the principal Timmy 44 study, and you can see the inhibition curves are far greater, a level of platelet inhibition with Prasugrel than we achieve with 600 milligrams of clopidogrel, either acutely in the first 24 hours or over the first 2 weeks. So it certainly is not a way to achieve Prasugrel-like platelet inhibition. And then very nicely, the way the trial was designed, even though it was against 300 milligrams of clopidogrel, there was a pre-specified landmark analysis in which the trial results were split into the first 3 days of results where there was a benefit of Prasugrel over clopidogrel, and then the results from 3 days to the end of the trial. Oops. And the reason why this was done is because the benefit from 3 days to the end of the trial, it's very hard to imagine that this would reflect anything about the loading dose. This really is about the maintenance dose of the benefit, and you can see there actually was more benefit from 3 days to the end of the trial over the maintenance period than there actually was in the acute phase of the trial. So I don't think it's a really fair criticism of the trial that the loading dose was a little bit different than what we use in contemporary practice. It may have been a slightly less benefit, but it's unlikely that it would have gotten rid of most of the benefit. Now, I think it can be said that the benefit of Prasugrel was driven largely by a reduction in non-fatal MI. That was the main benefit of it, and that makes sense because that's the mechanism by which antiplatelet drugs work. But if we look at the MIs, I think MI as an endpoint in PCI trials has gotten a bad rap from some of the glycoprotein 2B3A inhibitor trials where the benefit was really driven by the small elevations of CKMB that were biochemically detected. This is a categorization of all of the MIs that occurred in the Triton trial, and I think the important message here really is to look at where the benefit is. So you can see that as the categories increase from the left to the right side of the graph, the benefit actually gets greater. So the biggest benefit of Prasugrel in preventing MI was in the biggest and most prognostically important MIs, and in fact almost all the benefit is in the 5 to 10 times and greater than 10 times the upper limit of normal CKMB MIs. These are the big MIs, the ones that we all know are prognostically important for our patients. Third criticism that I sometimes hear is one of the big benefits of Prasugrel in the Triton trial was a reduction in stent thrombosis, and I'll show you those data in just a second. But a lot of people these days say we don't see that much stent thrombosis. These rates were awfully high. Were the doctors really doing a good job with the stents? Maybe these were earlier generation stents and not that well done. And I think there is certainly some concern about that, because here are the rates of stent thrombosis. Again, our most dread complication after PCI. You can see in the light blue about a 2.2% risk over a year with clopidogrel, which was halved with Prasugrel, and it was consistent across all the different subgroups, whether it was STEMI or non-STEMI, drug-eluting or bare metal stents, whether the patient got a 2B3 inhibitor or not, all of those different benefits. But a 2.2% risk of stent thrombosis does sound a bit high. But it doesn't look high when you look at other trials in ACS. And I think that's the key, is when we think about stent thrombosis rates, a lot of us think about our elective patients, and you get all mixed up in that, and you just don't realize how high the thrombosis rates are in ACS. So this is data from the Acuity trial, a fairly contemporary trial. It was not with Prasugrel, obviously, and it was looking at drug-eluting and bare metal stents altogether in non-ST elevation MI. And lo and behold, the 1-year stent thrombosis rate in the Acuity trial was exactly what we saw with clopidogrel in the Triton Timmy 38 trial, 2.2%. So it looks very, very reasonable there. What about STEMI? This is the Horizons AMI trial. Again, with everybody getting clopidogrel in this trial. And in these STEMI patients, again, whether you got a drug-eluting or a bare metal stent, the 1-year incidence of stent thrombosis was 3.3%. So I think when we look at these data, the thrombosis rates that occurred in Triton actually don't look unreasonable at all. This is just a population of patients that has stent thrombosis as a major problem that we want to combat. And then the last issue where I really want to focus my attention, and hopefully this is what's going to come up a lot in the panel, is the issue of bleeding. And there is some concern, and it's been present around the world, including in the United States, that the increased risk of bleeding might outweigh any benefit of reduced MI and stent thrombosis. And this is a real concern because we know that bleeding is not a trivial event for these patients. In addition to increasing the cost and the morbidity of our procedures, it also is associated with increased mortality. But I would just submit to you this graph, and this is something that Elliot Antman showed when he first presented the Triton data at the AHA a number of years ago. And basically what it shows is that every single advance that we've had in the field of antiplatelet therapy has been accompanied by this balance. Every time we lower the ischemic complication rate by some amount, it occurs with a price of an increased risk of bleeding. And if you think that lowering the ischemic complication rate at the increased price of some risk of bleeding is a bad thing to do, then you shouldn't be using clopidogrel because it does exactly the same thing. And you shouldn't be using ticagrelor because it does exactly the same thing. And you shouldn't be using 2B3 inhibitors because they do exactly the same thing. Everything we do has this side effect. Now, when they come around with something that is perfect and it doesn't achieve this, I'll be skeptical for quite a while, because frankly, I think if the drug doesn't increase bleeding, it probably isn't working as an antiplatelet drug. So how do we go about then optimizing this balance? And the answer here is really picking patients, identifying groups of patients who are relatively low risk for bleeding and using these more potent drugs in those patients, or identifying patients who are relatively high risk of ischemic complications where we can afford the bleeding because we know the benefit is going to be very substantial. And so one thing that's been done, again in the United States, is to focus in on this sweet spot, if you will, of patients who are younger, less than 75 years of age, who are heavier or normal body weight, over 60 kilograms, and have no history of TI or stroke, and that's what's shown in the middle here. It's about 80% of the population that was enrolled in the Triton trial, and here there really is, although there is still an increased risk of bleeding, the fatal bleeds are minimized in this group of patients, and the excess risk is really reduced to a substantial degree. So if we focus in on this sweet spot of patients who are at relatively lower risk of bleeding, we certainly can avoid a lot of the excess bleeds. And then we can talk about picking our patients well in terms of maximizing the benefit. And I think there are two groups of patients, and I think you know these well, but I just want to highlight this for you so you see the information presented once again. So one group of patients where you're already using Prasugrel quite liberally in Israel is the STEMI group. And this is, again, was about a quarter of the patients in the Triton trial. Here's the mortality data at 1 year in the Triton trial, and although there was no difference in mortality in the non-ST elevation MI group, in the STEMI group there was about a 1% absolute risk reduction. It was not statistically significant at 1 year, although it was statistically significant at 30 days in the trial, and it's very, very comparable to what we've seen now with bivalirudin in STEMI, and also with some other agents. A very important mortality reduction. What about bleeding? Well, this was a group of patients who it turned out actually had almost no increased risk of bleeding as well. So this is kind of the perfect group of patients for Prasugrel. You get a mortality reduction, you get no increased risk of bleeding, and I think a lot of this is because the STEMI group of patients tends to be a little bit younger, a little bit healthier group of patients than the non-STEMI patients. So they're the ones who have the lowest risk of bleeding. And then the other group of patients where we really can optimize the benefit are the diabetics. We all know that diabetic patients have high event rates after almost everything that we do. They have more active platelets, they have more extensive atherosclerosis, they have more restenosis, they have more stent thrombosis. And as a result of that, they're very, very good candidates for getting benefit from an increased, more potent platelet inhibitor. And so here are the data that have been published by Steve Wibiak, looking at the diabetic subset in the Triton trial, and you can see here again, this is the primary composite endpoint. It was benefited in the non-diabetic patients. There was about a 1.5% risk reduction. But look how much greater the risk reduction is in the diabetics. It's almost a 5% absolute risk reduction, a very, very substantial reduction in the composite endpoint in the diabetics. And if we look at mortality, again, it's not statistically significant, but certainly a very favorable trend. The diabetic patients treated with clopidogrel have a higher incidence of mortality than the non-diabetics at 1 year, and the absolute benefit seems to be modestly enhanced as well for mortality. And similarly, again, stent thrombosis, our most severe complication that's strongly correlated with mortality, again, substantially increased, almost double the risk in the diabetic patients, with a marked risk reduction of about 1.6%. So again, a very, very favorable group for treatment. And what about bleeding? Again, if we look at Timmy major bleeding, no increase in the diabetic patients. Maybe clopidogrel just isn't working very well in that group of patients at all. But so no real increase in Timmy major bleeding, although there still is an increase in Timmy minor bleeding as shown over here, but not highlighted in red. Finally, I want to plug my own research just a little bit. As some of you are aware, I spend a lot of time, probably too much time, thinking about health economics, and one of the areas we've done some fairly rigorous work is in the Triton trial. So we conducted a US-based economic analysis from Triton. It's not directly relevant to you, but I think it is, I think, interesting to look at, and helps at least put some of this information into context. This is the paper that we published now about 2 years ago in Circulation, again looking at this from the United States perspective. And this is what we saw actually. So we looked at all the resources the patients consumed over the duration of the trial, and what we saw was really substantial cost offsets with Prasugrel compared to clopidogrel, saving the healthcare system about $600, again, ignoring the cost of the drugs. We'll put the cost of the drugs in just a second, but ignoring the cost of the drugs. And it turned out a lot of this was of course driven by reductions in stent thrombosis and avoiding the need for repeat PCI. But there actually was also a substantial reduction in repeat PCIs that weren't even associated with stent thrombosis, which we believe, although we can't prove based on the way the data were collected, that these may have been subclinical ACS events that led to a PCI but didn't necessarily result in an MI. So about $500 of savings, which when you add in the higher cost of the drug in the United States, we still have clopidogrel that we pay for at a brand name price. So actually there was a cost savings in the United States versus branded clopidogrel. And if we look at this in terms of a cost effectiveness plane, so what we're looking at here now is the distribution of outcomes in the trial. We're sampling this to get some sense of the variability. And on the horizontal axis is improvement in life expectancy, what we expect, how much longer we expect patients to live if given Prasugrel compared to clopidogrel. And you can see that on average it's about 0.1 extra years of life that we expect them to get. And then on the vertical axis is the difference in cost. Points below the horizontal line are cost saving, points above it are somewhat higher cost. And what you can see here in red, this is the point estimate. This is the central point from the trial where we saved about $200 per patient and gained life years, and we call this economically dominant. These are our no-brainer therapies, things that save money and save lives. We love to do these things in medicine because then we have more money to pay for things for other patients. Now, of course, compared to generic clopidogrel, it doesn't look this good. Generic clopidogrel, there's a much different difference in price. And so we look at it compared to generic clopidogrel. We've now moved up above the horizontal line. It is more costly. It adds about $1,000 worth of cost. It doesn't add the full price of the drug in cost because, again, there were those cost offsets, but there still is a gain in life expectancy. And if you look at this dashed green line, that's a cost effectiveness threshold that we consider reasonable in the United States of about $50,000 per year of life gains, which tells us that we're pretty confident that even at a higher price, this is a price worth paying for the benefits that we're achieving with the drug. So I'll finish up now with some conclusions, and then hopefully we can get on to the cases, which I'm sure will be more interesting than the data. But I think it's hopefully obvious to all of you, and you probably wouldn't be here if it wasn't, that even though we have very good antiplatelet therapies already, aspirin is a very good drug, clopidogrel is a very good drug, there still is room for improvement, clearly both mechanistically, pharmacodynamically, as well as clinically. And particularly this is true in the ACS setting where we still have high rates of stent thrombosis. Prasugrel was the very first agent to demonstrate that a greater, more rapid, and uniform level of platelet inhibition can further reduce ischemic events, but it does come at this price of a greater major bleeding, which really accompanies every single advance and more potent agent in the field. And finally, careful patient selection, as I've tried to emphasize, is really what's critical to optimizing the risk-benefit profile of Prasugrel, and I think we've got some ideas about the best way to do this. We want to take into account clinical factors like age, the weight of the patient, the type of ACS, STEMI, non-STEMI, diabetes, again, as clinical risk factors. And we also may want to take account eventually, as the evidence matures, factors like genetics and platelet function testing to really individualize the care for every single patient. And I think I'll stop there, and we can take questions, or we can come up to the panel, whatever you think. Thank you very much.